Good day, everyone, and welcome to Complications of Surgery and also Voice Issues and Other Problems. My name is Lois Freed, and I am the facilitator for this session. This is session 334, so if that's where you should be right now, you are in the right place. I would like to also highlight Matt Baraka, who is the co-facilitator with me today. Matt, give a wave out there so everybody can see you. And Matt has been with me several times this weekend, and it's been great working together. We also have behind the scenes Alyssa, who is our producer, and she will be helping us to be very successful with our presentation. So at this time, I would like to welcome our guest speaker. So without further ado, I'm going to go ahead and bring up our guest speaker's bio and share it with you. Dr. David Myssiorek is an otolaryngologist, I had that all down before today, at Bronx Care Health System in Bronx, New York. He is the author of numerous articles on thyroid cancer surgery and other head and neck surgery. Doctor also is a graduate of New York University School of Medicine. He did his internship at Lenox Health Hospital and was chief resident at New York University, Bellevue. Dr. Myssiorek is a ThyCa medical advisor. Welcome, Dr. Myssiorek.
Okay, that's my cue, huh? I'm used to having a live audience, so if I look like I'm not looking right at you, it's because you're supposed to be over there. And hopefully next year we will be live again. Having said that, today I'm going to discuss with you folks complications of surgery. Many of the slides I'm about to put up, they're not that many, because I'd rather answer questions and float out thoughts. I give many thanks to Dr. Agrawal from Chicago, who basically supplied them to me at another time. So let me see if this works. So I hope you can see what I'm writing or wrote here. Complications of thyroid surgery are mainly due, of course, to the extent of surgery. We rarely have to deal with infection or blood loss or anesthetic complications, but our complications are more or less generated by the extent of the operation that we do. And that would include a thyroid lobectomy, a total thyroidectomy, and whether or not we throw in some form of neck dissection. So when will we only do this mastectomy and a lobectomy, which is very interesting because when I started training, people were doing this because they were afraid of the complications of a total thyroidectomy. And then during my training, everything flipped and they said, we're afraid of leaving any cancer behind. So we're going to do total thyroidectomies on everybody. So I became quite proficient at that operation. Nonetheless, the pendulum is swinging or has swung in the other direction. And now we don't feel that we need to do a complete thyroidectomy unless if there's a cancer that's small, or there's no extrathyroidal extension, or no evidence of lymph node disease. And that's an interesting point. I want to make it right here. It's not really, shouldn't be part of this discussion, but when I talk about measurable lymph node disease, I mean either palpable or symptomatic, or if it's radiologically evident. But a lot of us are trying to not just take out lymph nodes for the sake of taking out lymph nodes. It's not been proved, there's no great evidence that that works. So when would we absolutely want to do a total thyroidectomy? That's if the cancer is more than 4 centimeters, or if it's outside of the boundaries of the thyroid gland, or if it is spread to distant sites, or if it's spread to other sites, say lung. The reason we would take out the entire thyroid would be to make this person amenable to other forms of therapy. The recovery is, well, you guys know better than me. Recovery is about a week. I feel a little awkward saying this to people who've had thyroid surgery, since I only had parathyroid surgery. Recovery is about a week. We do see a lot of sore throats. There is fatigue. Following the surgeries that I've had fatigue also, not thyroid surgery again. There is neck swelling, and a lot of patients have temporary hoarseness, and some patients have low calciums, which I hope to address very briefly. But when we look at the extent of the thyroid complications, sorry, I just want to see how much time I'm using up. Hoarseness is a big one. Shortness of breath and swallowing dysfunction all follow thyroid surgery, but not necessarily in every person. All of this is a little bone of contention of mine, and that is that none of us, you, should have had surgery if you didn't have informed consent, and in that informed consent, this entire discussion should have taken place. I still hear about people who say, no, my doctor never told me that I'd be hoarse. My doctor never said I wouldn't be able to sing anymore or scream for my kids at the beach. And yet, it's this day and age, it should be par for the course. I think the numbers that are presented here are a little bit lowball. There's no such thing as 0% transient paresis. I think that just means the doctor who did that study wasn't looking. And 0% permanent paralysis, it's kind of unheard of. We do use a lot of speech and swallowing therapy for patients who've had a thyroid complication. And for the severe kind, we will medialize the vocal fold one way or the other. Probably going to get to that later in the question and answer period. Peculiar to this group is a superior laryngeal nerve injury, which is the one that allows you to change the pitch and volume of your voice. And we actually did a study through ThyCa where we found that 50% of the responders had this problem post-op. Now, I can't tell you much more than that, except most of them did get better. About 3 to 5% are permanent. Again, the extent of the surgery determines whether or not you have a complication. If you don't have a neck dissection, you're not going to have a complication of neck surgery. Again, we recover in about 1 to 2 weeks. In patients where we've operated, so I can show you out here, to get lymph nodes out, there can be shoulder weakness or a hematoma, a collection of blood underneath the skin. The central neck dissections, which are a little bit more prevalent, there's a possibility of hoarseness, mainly because you're exposing the entire length of the recurrent nerve to the surgery. And there's a possibility of a low calcium because you've accidentally removed or devascularized. I'm talking you, meaning the surgeon, has accidentally removed or devascularized parathyroid tissue. This is a paradoxical kind of statement here. The more surgery we do, the more complications we have. You would think that the occasional surgeon would have more, but there's something called cherry picking, and that is the lower hanging fruit get picked by the people who do an occasional thyroid. And am I still, can you still hear me? My screen just changed. Okay, good. Thank you.
Yes, you're fine.
Great, thank you. We do more extensive surgeries. We take on the harder cases, if you will. Nonetheless, with all that, the overall incidence of a hematoma, a collection of blood over here, which is life-threatening, is around 1% of the patients. This is the reason that I tell my patients there's a good chance you'll stay in the hospital overnight because of my fear of this. Hypoparathyroidism is a very interesting issue. People do post-operative parathyroid levels. They test calciums 5 times a day. This is usually for the total thyroidectomy patient, not for the partial. And I've adopted what I call lovingly the Terrace protocol. David Terrace is a surgeon in Georgia, and he just treats everybody as if they are, I hope I'm not misquoting him, a hypopara immediately after surgery. And to date, I have not readmitted a patient for this complication. And then over 3 weeks, they get a little constipated from all the calcium I'm giving them, and they never have a symptom. So that's something to consider. But for those of you out there who, I'm sure there's going to be at least one of you in this audience who has permanent hypoparathyroidism, for me, if you were to ask me as a surgeon, which complication do I dread the most, it's this one, because I can fix all the others relatively easily. This one is a bear. I've seen people on calcium supplements 8 times a day, and that I'm sure there may be somebody in the audience who's even more than that, but I hope my patients don't get it, and I'm sorry if you did. Again, without dwelling too much on this, the lateral neck dissection can result in all sorts of problems, the main one being a shoulder drop. And this is also a bone of contention for me, because a lot of people do a formal neck dissection where that nerve lives. And I know that we can get away with going right through the tissue and saving that nerve and taking these things out in pieces and have the same exact outcome, but no shoulder weakness. So it's just a bone of contention. Shoulder weakness can occur in this many people who've had neck dissections. 77% is an awful high number. I have personally seen chyle leaks. It's only when you do left-sided neck dissections. And Horner syndrome is this person has a slight Horner. It's a slightly droopy eyelid and a dry nose, and your pupil doesn't dilate. And what this is from damaging the nerve plexus along the carotid artery. Pretty uncommon. So with that, I think I'm going to stop sharing my screen and open up the floor.
Thank you, Dr. Myssiorek. If you would like to just start reading right down through the questions and answering them, you're more than welcome to handle it that way. Just let me know.
This will be under chat, I presume. Oh no, Q&A.
Yes. Mm-hmm.
What do I do about it? That's the very first question. I'm going to see if I can do these about hypocalcemia requiring supplementation despite a normal PTH. People become hypocalcemic, and your PTHs, all of our PTHs or parathyroid hormone levels are set with different barometers. My normal is probably not your normal. But even so, we don't go by, I don't treat PTH, I treat symptoms. And I will get that calcium up to where I need it to be without making them floridly hypercalcemic, because I'm much more afraid of the cardiac complications than I am about an abnormal laboratory value. So I hope that answered the question. Oh, so you were, this is from a responder or a question from CL, actually, oh, it's not from CL, sorry. Sorry. There's a question about being hoarse and a globus sensation prior to surgery. I can't answer that. And the reason I can't answer it, it depends on what your physical examination showed. If you were hoarse before surgery and it's because of a vocal fold paralysis, that's a whole different ballgame than simply having acid reflux and hoarseness on that basis. Unless you correct that acid reflux, you will continue to be hoarse. The little sidebar on that is our hypothyroidism will tend to make you gain weight after a total thyroidectomy. It's not unusual, and weight gain will lead to worsened reflux. I think Lois is saying I'm supposed to type my answers. I'm not doing that.
No, you don't need to type your answers.
Okay, good, because we will be here till next year.
No, you're fine.
Okay. So someone only had their right thyroid taken out, and how likely is there additional surgery to get the other side taken out in the future? Okay, it's an interesting question. Obviously, what you haven't included here is whether or not you had it taken out for cancer and which cancer it was. I don't know from this, and I hope I'm not sounding pedantic. It's not my purpose. You know, if you had, say, the follicular variant or a well-encapsulated follicular variant in just one side of your thyroid that's out, that's probably all the surgery you need, and that would be great. if it's cancer. If it's not cancer, I don't know why you would be going, for another surgery. The next question is, I was a math minor in college. I still can't balance a checkbook, but do 2 surgeries increase the chance of permanent voice damage? Well, that doubles your chances of damaging a nerve. So the answer is yes. But if you went to a surgeon who had, did a normal procedure on the one side, there's no reason to suspect that it won't happen on the other side. And she or he will, I'm sure, be extraordinarily careful if that were to arise. Oh, this is a great question. How common is it to have thyroid cancer spread to the nerve, to the vocal cord? I don't think anybody knows. The reality is, I do know whenever I have a patient who comes in already paralyzed, that I always find cancer on that nerve. During the dissections, there are many, many reasons for it to get tough for us to dissect out that nerve. I took out a 20 centimeter, I got some this big. I took out a thyroid from some gentleman, and my monitors lost all track of his nerve. And indeed, he's hoarse today, last week. And so large size will do it. I feel awful about it. Patients who have Hashimoto thyroiditis, because of all the excess scarring that they have from their disease, not just the cancer, but in addition, they have a thyroiditis. Those folks have an increased risk of damage to the nerve, but the nerve isn't usually from thyroid cancer directly spreading. However, when we do see cancer on the nerve, I think, I can't speak for all surgeons. I know I make an attempt to spare the nerve, and after a while, it just doesn't pay. We do have other ways of, you can leave cancer. One of the people that trained me left cancer on someone's nerve 20 years ago. He retired, patient came to me, and her thyroid cancer came back. We all knew it would because we left a little bit behind, and we simply took it out. This time her vocal fold was already paralyzed. She's a voice coach of all things. And we knew what was ahead of us. And nonetheless, at this point, the cancer had committed itself, and her voice was already damaged. So it was a little less sad, but still sad nonetheless. So I think I'm dancing around the answer, which is I don't know, and I don't think anybody knows. And I do know when we see invasion, we remove the nerve. When we don't see invasion, we try to save the nerve. Okay. For a 2 centimeter right-sided, screen is moving, no apparent spread to lymph nodes, low risk diagnosis, do I recommend a partial? Ooh, that one I recommend a partial if I can. If there's no evidence, no clinical or radiological evidence of lymph node spread, 2 centimeters, I flip-flop here a little bit. I can't explain it. So there are unspoken things about patient management. If you have an unreliable patient, you may want to go with a total thyroidectomy, simply to get rid of all the disease. If you're not that thrilled with your imaging, right? You're not thrilled that it's 2 centimeters right away. There's a third option here that's there's one a lot of us are playing, and that is you just remove one lobe and then you check the pathology. I think this is like genetic memory, if there's such a thing among surgeons. That is, 30 years ago, the thought of taking somebody back for vision surgery was anathema. You just didn't do it. You'd rather eat glass. And these, I'm finding lately that going back is not the worst thing as long as you warned your client that that's a possibility. Because sometimes that 2 centimeters may be 1 centimeter. That 2 centimeters may be 4 centimeters. You may have trouble inside the patient where you've run into trouble with the nerve or damaged a parathyroid or two. And those are all things that would mitigate against more surgery. Again, more surgery increases your chance of complication. So I know I didn't give you a concrete answer, but the 2 centimeter nodule, again, it depends on the patient. A lot of the times patients will say, I don't want to go back. If you find something, take it out. You can rely on frozen section. I think for a frozen section that came back positive, I might just go ahead, especially if there's a nodule on the other side. And not to be flip about this, but there's almost always a nodule on the other side. That's just something to consider. Wow. To Patty, how to deal with the chyle leak and lymph node drainage issues. Well, it's all related. It's not really so much lymph node drainage as it is the chyle leak. And what I haven't seen one in a long, long time. I'm knocking wood. Having just said that, I'm sure my next patient will have one. But the trick there is to start the patient on a medium chain triglyceride diet, no fat whatsoever, in their external diet. And what we've been doing is giving people cold octreotide, which I believe it's injected, and it's relatively expensive, but it does cut chyle leaks. So God bless. I have gone back and tried to find the leaking area. Going back, say, a week or two later, in my experience, has been not just a nightmare, but it just doesn't work. To those of you who are not surgeons listening to this, sewing up a chyle leak is tantamount to sewing up 2 pieces of wet toilet paper. It just doesn't hold a suture. And if you start digging down deep, you have all sorts of wonderful structures there, like the jugular vein and the carotid artery and the recurrent nerve, and even in some cases, the top of the lung. So I'd rather, that's the place where we tried pressure dressings, but octreotide has been somewhat of a game changer. Okay. To anonymous attendee, I guess that's AA, it's kind of funny. Ever since my partial thyroidectomy a year ago, I've had trouble swallowing pills and vitamins. Nowhere near as bad as immediately, but it persists. Oh, is it due to the thyroid, to scar tissue? I guess it could be, but the best way to elucidate this is you either go to an otolaryngologist, and if you're lucky enough to have somebody who's a swallowing expert in that facility, that's what you do. You get a modified barium swallow. You get to see where and what stops. Sometimes it could be, as an earlier question, it could be something as simple as reflux disease. Why things come up after thyroidectomy is not always known. So again, it's very difficult. When I usually have these sessions in the live sessions, and I've been doing them for 23 years, it's a back and forth. And this is like a comedian, that's what I did also. This is like a comedian not knowing that his audience has left the room. So do some lobectomy patients experience lifelong issues with this? Probably not. But, well, having said that, I should say probably yes, because there's no such thing as never. And that's the best advice I have for you. But this is one that, if it's bothering you, it clearly sounds like it is. A modified barium study, and a person who does a lot of swallowing issues. That is, your average otolaryngologist will take care of that. Central and lateral neck dissection. I'm sorry, I'm reading this thing to myself. Wait, why am I getting something that says from oh, it's Alicia to Abby. Okay. If someone had a central and lateral neck dissection and lost most of their vocal range, but developed and still experienced neck pain on the side of surgery, with triggers related to voice usage over 4 years later, laryngoscopy is negative. This person has had myofascial release, physical therapy, and speech therapy didn't improve things. Our study showed that when people did go to speech therapy, they were able to modify a lot of the problems. part of the issue is most patients don't really have voice issues because most people aren't, by the way, I'm speaking of people who have voice issues. They're not as severe, say, as a professional singer or as that voice teacher that I took care of, or as Amelita Galli-Curci, who was an opera singer 120 years ago or so, who lost her superior laryngeal nerve and never sang again. So the answer is you do the best you can. I can't give you much more than that. I'm sure this has to do with scarring, and I'm also sure it has to do with the extent of damage to your superior laryngeal nerve. That nerve is about the size of 6 human hairs. So it's not a big, robust nerve, and it's not, you can't just sew it to something else. It's also a sensory nerve. So there's a lot going on with that particular nerve. Is it due to muscles? I couldn't tell you, but I've done this with singers, and that is when our voice therapists don't work, singing coaches do. There are probably a lot more patients out there with this, but the vocal demands of most people are not that great. Not all of us are trial lawyers, not all of us are singers, not all of us are priests. But they're still, look, I'm not saying a voice is unimportant to other people, but most people, when I tell people you may not be able to sing after the surgery, so many people say to me, I didn't sing before surgery. You know, they say that until they get in the shower that first time, and doing that whole solo from Bohemian Rhapsody fails them. So I hope that partially answered your question, but if you're not happy with the way things went, take another avenue, take a different voice therapist, something. And somebody might find what works for you, if something can work for you. Can calcium supplementation cause plaque in the arteries? Oh, for God's sakes, I hope not, because I don't have many arteries left and I'm taking calcium. So the answer is no, it shouldn't. Plaque is from cholesterol, and no, it should not affect you that way. My mother-in-law used to talk about hardening of the arteries in her brain. That led to some lethal conversations. I hate this question, and I'll tell you why. What is considered a high volume surgeon? How many thyroid cancer operations would they do per year? The high volume number comes strictly from the number that are done every year. And I will be lying to you if I told you I know the right answer, but I believe it's 50. And it's not 50 thyroid cancer operations, it's 50 thyroid operations. So that number may be wrong, because when I was doing over 100 a year, I never considered myself a high volume surgeon because I worked with somebody who was, and he was churning out like 200 to 300 patients a year. And I found that astonishing, because you do the math, that's 4 a week with no vacations. So I'm not sure that answered your question entirely, but it's an honest answer. I don't know the exact number. And most high volume folks are not in private practice. So this is to SJ, who has a papillary thyroid tumor wrapped around the laryngeal nerve and is now pressing against the nerve. Voice is getting bad now. Voice therapy, the question is whether or not voice therapy will help. This is a great question. In my prior life, I was a speech therapist. This is a structural problem. I don't think that voice therapy is going to work in this case. I wish it would, but there's a bigger issue here, isn't there? It's not that you're having some pressing on the nerve, it's that you have a cancer that's pressing on the nerve, and that needs to be addressed. So, you know, if it's getting bad now, I'm going to say something. This is a surgeon speaking. If you haven't had that thyroid operated on, and now your voice is getting damaged. I was just in a prior session with an absolutely lovely man named Mark, who had a problem that probably started this way and got much worse. And my point is going to be, if that's the case and you have not had surgery, have surgery. And if you've had surgery, you need more therapy. More, I'm not talking about voice therapy, I'm talking about treatment for your cancer. Okay. Let me see. Is it very common to gain weight after total thyroidectomy? You know, that should be answered by virtually everybody else on this site. But the answer is yes, it's common to gain weight after thyroid surgery, not just because you're hypothyroid. Don't forget, after any surgery, we all get a little depressed. After any surgery, you have a little bit of fatigue. After any surgery, after any cancer surgery, you're depressed. Well, I shouldn't say you are. Most of us are. And because of that, it's, weight gain is not so surprising. I wouldn't attribute 100-pound weight gain to lack of synthroid, because at some point you're going to be started on a supplement. So is it very common? I think it's very, very common. And I know after my cancer surgery, I gained weight. Everybody thought I would lose weight because cancer is so damn destructive, but I gained. And having a strong family history of diabetes, well, I don't mean to sound persnickety, but take care of yourself. Don't try not to gain weight. Try walk every day. I wear a Fitbit now every day to make sure that I get my 10,000 steps. I don't get a chance to eat at work, which is great because it's a great way to lose weight, not eat. But seriously, you have to take care of yourself, particularly if that one's hanging over your head. And your internist at this point most likely has checked you out for pre-diabetes. I currently work in the borough, in New York, which has the country's highest per capita rate of diabetes and obesity by county. There's no county worse than where I work. And many of my patients are diabetic. So the answer is, yeah, you got to deal with it. And this is not one that you can wait for. This is one that you have to start developing better habits now. Susan, congratulations on your recent surgery. So your right side, I'm sorry, I'm reading the question. I'm just gonna have to read the questions out loud at some point. So this is, I am 6 weeks post partial thyroidectomy with marked voice changes. My tumor was wrapped around the right laryngeal nerve and had a loss of signal. I had that in somebody 2 weeks ago. That's why they stopped the thyroidectomy. That's what I do. And you have medullary, okay. You're told that an injection of saline may make a difference. I can speak to that. It should make zero difference. Saline will be absorbed instantly. You could have an injection of, there's Ristylane, there's all sorts of stuff that we inject in the vocal fold now. You could have a reversible procedure on the skeleton of your larynx. I still think it's kind of early to do that. We do wait. We do want you to go for voice therapy. Again, this is a tough road to hoe, Susan. You have medullary thyroid cancer. So I believe that's calling the shots rather than your voice. I agree, though, that you should, to avoid removing the other side. Did they remove lymph nodes from your neck? See, I'm asking a question that I won't get an answer to. But if they did or didn't, did they know you had medullary going in? That's a very important question because that would dictate whether or not they got aggressive on the other side. But I'm speaking to this the best I can, waiting to see a specialist in voice issues till January. That is the wait because you can't get an appointment, or is it because it's an appropriate time to wait to see if you recover your nerve? If you recover your nerve, we're in really good shape. Everything will fall into place.
Dr. Susan did answer that removed 5 lymph nodes and new medullary going in.
So thank you. Only 5? Susan, this is it's not going to work well for everybody. If they remove 5 lymph nodes that had medullary, or do they remove 60 lymph nodes and 5 of them had medullary? If they only remove 5 lymph nodes, it's somewhat limited dissection. And is it the lateral neck or the central neck? While I'm waiting for a response, I'm going to go to the next question. I got a feeling I'm coming back to Susan. What are my thoughts on medialization for a paralyzed vocal fold? This person loses, Graciela, I'm assuming you're female, you lose your breath very easily. I think it's a phenomenal procedure. In my hands, the success rate has been sincerely off the charts and very rewarding. We have people who come in, women who sound like men and men who you can't hear, and they're talking to their relatives from the operating table on a cell phone. It's a little gimmick that I like to do. It's pretty impressive. That's how good it gets. And certainly for shortness of breath, it's a chance for me to spring somewhere else right now. Your vocal folds are, you can see my fat little fingers here. They come together when you're holding your breath or speaking. They come apart when you're breathing. When you're eating, they should be closed. When one of them doesn't move, depends on how severe that lack of motion is. I need a little help. So if this one can make it all the way over, if the one that's working can make it all the way over, we're good. But if it only goes this far, we've got to give this one a nudge to the middle. This lack of this breathy voice, which I think you're describing, will cause you. I can count to 45 on one breath, out loud, meaning I'm expelling air. People who have a vocal fold paralysis cannot do that. We have something called the mean phonation time, and patients who have had vocal fold paralysis will have a mean phonation time of around 8 seconds, meaning 1, 2, 3, 4, 5, 6, 7, and they're done. And I'm not mocking anybody in the room. It's devastating because in order for you to give the talk, for instance, that I'm talking, you're going to be out of breath within 10 minutes because of the physical labor you have to perform to breathe that many times. So it's that, and also patients who can't completely close those vocal folds, when water comes down, they're going to cough. And coughing is a bad deal. It's a form of aspiration. And I mean, coughing is good, but having to cough is not. It's exhausting, and it also makes people not want to eat, especially liquidy stuff. So I think it's a great procedure. I wouldn't do it immediately unless the doctor said, I cut that nerve, I saw it, it was completely encased in cancer, and I cut it. But even then, there's some patients who over time that vocal fold will come to the middle by itself. So there's a reason to wait and see how it turns out. I did a couple last week on patients that have been waiting because of COVID, have been waiting a long time for their surgeries. So did Susan get back?
Yes, she did. 5 of the 5 had medullary, and it was a central neck dissection.
5 of the 5. So it's only a central. So yeah, this is problematic. And they knew it was medullary going in. I'm surprised. See, this is where I got to be careful, because I'm giving an opinion about what another doctor who's actually treated the patient did. So with a gigantic lump of salt here, many folks would have done a lateral neck dissection as well. As I alluded to in my very brief slide presentation, central neck dissections they're problematic, but absolutely indicated in medullary thyroid cancer. So the fact that they lost signal it's a good thing that they stopped, because they can come back. It's just now that they've done a central compartment clean out, there's going to be a lot of scarring. But they didn't have a choice. I mean, the choice was to put Susan at risk for bilateral vocal fold paralysis, which 90% of the time results in a tracheotomy, which is something that we do warn patients about, but we pray to God that it doesn't happen. Okay. Let me see. I am so confused. I don't know where I am right now. Shoulder pain. There was a patient, there was something on shoulder pain. Oh, that's good because I'm getting to hit all the things that are in the slide presentation. Getting shoulder pain following a total thyroidectomy is really unusual. Getting shoulder pain following a total thyroidectomy with a neck dissection, I think my prior numbers showed that it was around, could be as high as 70%. So I'm not trying to make this difficult, but I've never had this in a patient following a total thyroidectomy. I have seen it in patients who've had neck dissections for whatever reason. The nerve that goes from your skull base through your jugular foramen, way up here, comes down into your neck, wraps around your jugular vein, and then comes out to your shoulder and allows you to do this. Doesn't seem like much until you try swimming or putting on a jacket or taking off a shirt or raising a tennis racket or holding your grandchild above your head. It just can't happen. It's an avoidable injury, but not all the time. The act of saving the nerve, of dissecting it out of all of the tissue that contains lymph nodes, can, in and of itself, be damaging by devascularizing that nerve. Having said that, the questions just keep coming. Having said that, I will say that it's not always avoidable. What I try to do is, gosh, there's something coming up from KK. Okay, missed it. I'm getting text messages in the middle of the question, so I'm getting a bit.
Somebody wrote, can you clarify the name of the vocal cord repair surgery just discussed? The transcription didn't record the name of the surgery accurately.
I will back straight into that after I complete answering this question. So what I do when I'm doing a neck dissection for thyroid cancer is I will cut the thyroid specimen in half, not the thyroid, the neck dissection in half, and remove that half that's on this side of the nerve, and then remove that half that's on this side of the nerve, leaving the nerve effectively untouched. That way I don't have to worry that I devascularized it or damaged it or stretched it. Probably the more common injury is stretching because we are pulling that nerve this way, I can use this way and that way over a lump. And after a while, it disappears in the background. That's wonderful. After a while, the nerve says, I've had enough. So now the voice surgery that we're talking about is medialization laryngoplasty. And that is where we, under local anesthesia, we remove we pull up the skin of the muscle over the voice box, and I make a hole in the cartilage, and I put a piece of silastic in there, medical grade silastic. And it just sits there. It's totally non-reactive, and it pushes that bad vocal fold. Okay, that's a judgment. It pushes the vocal fold that is no longer working so it can contact the good vocal fold. And that's called medialization laryngoplasty. There are some people who do medialization laryngoplasty by injecting silicone or Ristylane, which is hydroxyapatite, into the vocal fold so it gets pushed over. That the patient more or less needs to be asleep for. I do know some people who do that under sedation anesthesia, but it's difficult. It's hard for the patient. Now, having said that, our great vocologists, I know several in San Francisco, Clark Rosen, for instance, I'm not supposed to do that, but I did it, will do this in the office. Patient sitting in the chair, numb up the skin, put the needle in, and inject it under direct vision with a scope through the nose into the voice box. That's a very slick procedure. My office is not medialization laryngoplasty, laryngoplasty. My office is not equipped to do that currently. But you can find it in many centers. So I think I answered the shoulder pain. Oh, by the way, the answer to shoulder pain is rehabilitation, physical therapy. But if the shoulder is really denervated, meaning the nerve is cut and the muscle is atrophying, the only thing that will help that is finding the two ends of the nerve and putting them together, or putting it together with another nerve that provides motor function, and do that carefully. I did that as a fellow, and I broke a person's shoulder because I hooked it up to a nerve that was helping him breathe. So the nerve was constantly putting in impulses into his shoulder. So every time he took a breath, this was happening, but he hypertrophied his shoulder and broke it. I've seen it all. I like this question. What are the causes of, I'm not saying I didn't like the others, but what are the causes of feeling of pressure and tightness in the thyroid area in the months following thyroid surgery, even after a lobectomy? So this is a really good question, because first of all, every violation of the human body, this is what I was taught when I was a fellow, is remembered for about a year. So if you had your gallbladder out, you're going to feel tightness and swelling, and it's not going to feel quite normal, even if it was done laparoscopically. You're going to always be aware of that surgery for about a year. I was hit by a car in Paris, France. I had a very colorful life. I'm sure he was aiming, and my leg was broken. And for a year after that, if you came anywhere close to that leg, I was dodging out of the way. I could run, but you weren't getting near that leg. And it's not tender. I was very aware that I had been injured. So that's one thing. The other thing is that we operate in the thyroid bed. We remove the thyroid by pushing muscles away from it. We usually don't do a lot of cutting. We do a lot of pushing, so the thyroid more or less gets moved out. If you've been dissected, meaning if we had trouble finding the nerve or had to find a parathyroid gland, and suddenly the whole operation gets a little bit more extended, and that puts us into muscle, right? You're looking for a nerve and you can't find it, so you are looking in tissue that you expect to find it in, and sometimes that tissue is muscle. And any damage to muscle, anybody who's had a COVID shot knows that for a week, you're going to know that your muscle was violated. And by the way, if you haven't had your COVID shot, get it. I don't want to go through that a third time, thank you. So I'm hoping that answered the question. Again, there's very little feedback loop here, so I'm doing the best I can. So, this is a question, I love this. So a dissection is only needed if the cancer has been confirmed to have spread to lymph nodes, right? I've just been diagnosed with papillary right side, no apparent lymph node spread, and the surgeon didn't mention dissection. Is it possible that it can be decided dissection is needed during? Yes, it's absolutely possible. And that surgeon would be derelict if he didn't. He or she would be looking at a nodule of cancer in your neck that is going to plague you for the rest of your life unless you deal with it. And yeah, understand something. I'm a surgeon, so what I'm about to say is going to sound incredibly surgical, but by and large, thyroid cancer is a surgical disease. Maybe that'll change in the next 10 years, but for right now, it's still a surgical disease. Nothing will replace a thyroidectomy until they get the right chemotherapy, and very little is going to replace the neck dissection. Radiation is okay, but radiation is actually more destructive than surgery for this entity. So there you go. My father-in-law used to say, everybody's entitled to your opinion. There it is. So if someone were to see a nodule in your neck while your neck is open, or feel a nodule, which is the much more likely scenario, and say, I'm not in the mood, or gee, I have tea time at 2 o'clock, I've got to go. That's not going to happen. I would tell you that your doctor will undoubtedly take that lump out. Probably take out all the little lymph nodes surrounding it as well. That amounts to a modified neck dissection, but better than just letting it stay there. I just don't understand how we could do that. It's like watching a child walk into the street while there's traffic coming. You don't think about yourself. You take the damn thing. You take the child out of the street, out of harm's way. I'm sorry. The name that just came up here is on a question. You're not in charge of NIH, I hope. If not, we shared an office several years ago. DK. 14 months ago, the nerve controlling your left vocal fold was sacrificed to remove a tumor. You lost your entire thyroid. Oh, and 2 parathyroids. Yeah. So they did a total thyroidectomy, and I guess I'm summating this. Your left side is paralyzed. You're saying that you get some motion on the right vocal fold. In the business, that amounts to very little, right? That's why you have a tracheotomy. And tracheotomy, for those of you who are unindoctrinated, is done so he can breathe. Otherwise, his vocal folds are shaking hands all the time, meaning that he can't open them, meaning he can't breathe. Your voice isn't yeah, well, this is a textbook description. His voice isn't terrible at this time because the vocal folds are in the position they should be in to speak. The problem is if David and I were to walk down the block, he would have to stop. Well, if he didn't have a tracheotomy, he wouldn't be able to complete that 1 block walk. He'd be gasping for air because his vocal folds weren't letting any in. You're able to sing a little. Oh, God bless. Playing a wind. David, how do you play a wind instrument with a tracheotomy? Wow, I'm impressed. I think you're doing phenomenally. The question you're asking is one it's part of the holy grail of ENT surgery, and that is, how do we get a person whose both vocal folds are paralyzed to move again? And they're working on sensors, and they're working on all sorts of neurologic stuff and rerouting nerves to the voice box. Thus far, is a little promising, but I don't see anything on the immediate horizon. The choice is for that person, tracheotomy and normal voice and normal swallowing, or lose the tracheotomy, resect part of the vocal fold, and have that patient lose a little bit of voice ability, but breathe better. And that's a very individualized choice.
And Doctor, David Kessler, I believe, is adding down below, and I think he's written, I've got about 2 millimeters of motion, and then speech valve or plug on the trach makes it possible to play wind instruments.
Well, so you're making the best of a bad situation. That's highly impressive. It takes a lot. Those folks who doesn't know what he's going through, it takes a lot of motivation. Way to go. So you know the solutions as well as I do. Yeah, the only other thing to consider, if you haven't done this already, and I suspect you have, would be to go to a person who only deals with voice box. Those are laryngologists. They don't exist in every city, but sometimes that opinion is worth it. We do a procedure called an arytenoidectomy, where we increase the cross-sectional area of the larynx. And if the patient can breathe well after that, they can also voice well enough. They're not going to sing, and the tracheotomy can be removed. That's a game changer, because people who, if you're not aware of it, if you have a tracheotomy, you can't go in a bathtub. You can't go in a pool. You can't go in an ocean or a lake. If you're an avid fly fisherman like myself, it becomes a life-threatening sport. Just because once your neck goes underwater, you have no way of keeping the water out of your lungs. So my hat's off to you, David. Way to go. Oh, this is an answer live. Wait. Okay, got that. Thank you, David. How would I say surgeries and techniques have changed since 1978? Wow, this is only an old person like myself could answer this question. In 1978, Bellevue Hospital, where I trained, got its first CT scan. We were not allowed to use it for any of our head and neck patients because the only people who could use it were people. We couldn't use it for people with gunshot wounds to the head. We could only use it for neurology, for headache purposes. So since then, we've had CT scan, MRIs, PET scanning, refined radioactive iodine scanning, refined radioactive iodine, indications. Not everybody's getting radioactive iodine after thyroid cancer. I alluded to this before, we were afraid to do total thyroidectomies, then we weren't afraid to do them, then we realized that not everybody needed them. So surgery has changed because fortunately the modern surgeon, I'm not sure I'm going to include myself, has grown with science. Science is still pretty important. And we have alternate ways of treating certain things. Another thing that has come across the scene now that the last 20 years has been monitoring. Monitoring the vocal fold with electronic devices to see if we're threatening the nerve. Yeah, the answer, Matt, is yes. The monitoring of the nerve has probably done two things. It's probably helps in the long run, but what it has also done is it's enabled the part-time surgeon to do this operation because they think that the monitor is going to find the nerve for them every time. And I've seen tragic mistakes with this. So if you don't know the anatomy, it doesn't matter if you have a monitor hooked up. I liken it to giving me a $400 tennis racket. I'm still going to play like a $20 player. So the the monitoring that we have, we use it to confirm that we found the nerve. We use it in patients where there's a huge thyroid or a lot of scarring or previous surgery. Those are times when I will use monitoring. Otherwise, I'm going to find the nerve every time or just beat my head against the wall. Okay.
Dr. Myssiorek, we are at almost just a minute to the top of the hour, but we will go another 7 minutes.
Like
Just continue, and I'll let you know when we're getting close to our 7-minute wrap up.
Okay, because I can feel my throat starting to go. But let's just going from the top of the list here. Calcium supplementation came up earlier because you have no parathyroid functions and you're having plaque buildup. I don't know about that. That's one, if that's what's happening, I guess the questions I'm going to have are which arteries are building up the plaque, and are you seeing, if it's cardiac or carotid, are you seeing a heart doctor? And if it's in your kidneys, are you seeing an endocrinologist? Well, you must be seeing an endocrinologist. And not because I don't want to float any misinformation here. That's a question that must be answered by your endocrinologist. Like I said, I said in another session, I had a heart attack and I have 4 stents because I have plaques up, what's left of my ailing myocardium. And they're going to be made out of cholesterol. Thank you, Mom and Dad. But this is something that should not be answered in this particular venue. I would take that extremely seriously because if it's cholesterol, it's reversible. And if it's something else, then we as a medical community have to find something better for you. You have a hoarse voice due to GERD or complications of surgery. Can voice therapy, voice therapy can always help. right? You have an abnormal voice. There are little tricks of the trade. Part of the issue with GERD, when people spill stomach acid or even vapor of stomach acid vapor on their vocal folds, will set them into spasm. It'll make their lining a little thicker. But some of it also has to do with lack of hydration. And there's little tricks of the trade that a good voice therapist will give you. So I think it'll help. Is GERD a lifelong process? 44% of Americans have GERD at one time or another. I think that's probably a lie. Anybody who's ever been on a binge will have had reflux. But seriously, it's something that you can get a hold of, get a handle on, and it requires no late meals, avoiding certain food groups. I'm not going to get into them now because it's not the purpose of this session, and trying to get about 8 hours on an empty stomach. It'll work wonders, and you'll also lose weight. So I personally have used the intermittent fasting diet. I'm not promoting it, but it worked, and my GERD got under control with it. Otherwise, on a proton pump inhibitor and possibly an H2 blocker, it can take months. Okay, and if you have an H. pylori infection, it doesn't matter how much PPI we give you, it's still going to be hoarse. So talk to your doctor. Why don't cancer patients go to pre-op class? To be honest with you, I think ThyCa and the ThyCa meetings are pre-op class. If you know you're going into that surgery for cancer, I can't think of a better place to be, because it's factual and fact-checked information. That's what that's why the site, as opposed to any other site, which there may be other thyroid cancer sites. This is the only one I trust because it's the only one I know. And I think I know I used to know most of the speakers. So the answer is, I don't, thyroid cancer, the big talk happens after, because if 1 in 20 patients with a nodule has thyroid cancer, that means we are freaking out 19 patients who may not need to be freaked out. Okay. I told in another session that I do have a cancer. I kind of know what it's like to hear about it. Don't like talking about it. I don't like waking up thinking that my backache is a cancer, but I do. And I deal with it. So I don't know why I would expose other people necessarily to pre-op counseling. Hip surgery is different. It's not for cancer. Just as gastric bypass is different. It's not for cancer. We know the outcome. The other position, the other question, really quick one, is there any other treatments for the hoarse voice other than voice therapy? Their answer is, if it's severe enough, surgery. Someone's asking the Siemens law question. Why do some cords paralyze in medial and some lateral position? The best answer is we don't know, but the nerve that goes to your voice box, 3/4 of that nerve is dedicated to the part of your voice box that pulls the vocal fold in, and 1/4 is the part that pulls the vocal fold out. And that's usually the one that gets destroyed. So it doesn't, some, more often than not, there's many more muscles pulling that vocal fold in that it's that's adduction, ADD, D as in dated. That's it all depends on what part of the nerve gets destroyed, and if it's a whole nerve, it's just, I don't know the answer. I don't think anybody knows the answer to that specific question, but that's why we wait 6 to 9 months to see how the patient turns out. So now I'm up to GO. Oh, you're welcome. To GO here. Oh, a couple of questions from GO. Oh boy, had a total thyroidectomy in 2006 by general surgeon. Didn't shop around. Don't blame that on yourself. And you had a paralyzed voice for 1 month before you went to speech therapy. It helped the left vocal fold come back. Oh, you're an interpreter. Yeah, you got some flatness in your voice and hoarseness. First of all, if you're using your voice every day, as I am doing right now, it doesn't show up when I put it over there. You need to stay hydrated. Dry vocal folds don't work well. If you're talking to patients for about 8 hours a day, by the time you get home, you don't want to do anything. And you start using muscles that you're not supposed to use to voice, so you get a little bit of fatigue. I know when I come home at night, I tell the other person here that I'm not Clint Eastwood. This is the best I can do. So yeah, you have to protect what you have, and in your case, it would mean taking breaks, taking plenty of fluids. To a degree, you might have had some incomplete neurologic recovery. So whereas you recovered 90% of your nerve, I'm making these numbers up, that still means that 90% is doing the work of 100%, and that's like asking 10 people building the pyramids. Well, only 9 of you are going to move this rock up the hill. Paralyzed right cord, shortness of breath was it your left or your right? You know what? I think we have like about a minute left. I want to get to one more question. I'm not avoiding you, Gio. It's a very difficult question to answer. So here, this person has partial paralysis of both vocal folds and semi-permanent implants, and they help. That's great. Wait, somebody moved my thing. Okay. But not enough to get back to teaching and performing on the clarinet or walking fast. One thing that'll help you in terms of teaching is a microphone. It sounds crazy, but a microphone, because they now have all sorts of devices. They have all sorts of FM devices that, depending on who you are dealing with, if your audience can wear a device, you can speak to them pretty clearly. As I am now, I can tell you right now, if I had to go out and coach girls soccer, we would lose. Well, actually, we'd probably win. So, and practicing the clarinet takes a lot of breath control, right? And that's going to dry you out. So these are some basics here. Just rest when you can, save up your energy for when you need it. I did not go into the shower just before this and do the entire, rock opera Tommy by myself. Prevent yourself from hurting yourself, but this is all, it sounds like common sense. It is. There's more to this than just voice therapy, and there's more to this than just lifestyle change. For right now, you do the best you can with partial paralysis and implants. So you went to a very up-to-date doctor if you have bilateral implants, and I would tell you that that's the person to ask, because this person's better trained than I am.
Dr. Myssiorek, we just want to thank you. We're going to let you rest your voice now. You have been so gracious to answer as many questions as you possibly can, and we really, really thank you so much for that. Again, thank you so much for being with us today, and a lot of what you said, I went through myself with my voice, and I love to sing, so I really try and protect it and hydrate as much as possible. Thank you so much, Matt, for being in the background there with me, and also our producer, who was just helping us out, Alyssa, so wonderfully. Have a wonderful day, and thank you again, Dr. Myssiorek.